We'll be starting with our next session now. Once again, before we do that, let me quickly remind you to use our hashtag for the day. We'll be very happy for all of you to spread the word around on your social networks. The hashtag is IAMAI Digital Health Summit 2023. Please use that on your social networks. Shall we start with the next session now? Now? Shall we start? Okay, wonderful. So we're talking about digital leadership. Is telemedicine the future of healthcare? Our esteemed panelists, pioneers in the field of digital health, will share their insights and, of course, give their expertise into the topic, transformative power of telemedicine. I would request all of you to join me in welcoming our panel, Dr. Alexander Kuruvilla, Chief Health Strategy Officer, Practo, and Co-Chair of IAMAI HealthTech Committee. Ladies and gentlemen, please welcome Dr. Kuruvilla once again on the stage. Joining him is Mr. Saurabh Kochhar, co-founder and CEO at Meddo. Probably the most good-looking man coming up on the dais. There we go, fantastic. Dr. Nirod Kumar Singh, Executive Vice President, Health Parliament, is also joining us. It's truly an honor to have the gentleman with us. Thank you so much for joining in. Please join me in welcoming the gentleman. We also have Mr. Yuvraj Patil, Head Public Policy and Regulatory for Reliance Retail, joining us as well. I'll request you to join me in welcoming the gentleman. And to moderate this fabulous session, we have Mr. Rajat Garg, CEO, MyUpchar. How many entrepreneurs in the room? If I can request you to raise your hand if you have any entrepreneurs in the room. Great. Obviously, you're in the right room. But if you applaud louder than the rest of the people, there might be a funding coming your way. So, just saying. Let's have a round of applause for our panel now. Thank you.
Thank you. Session after lunchtime is especially hard. So we'll try not to, bore you and not to put you to sleep. We'll keep it interesting. But teleconsultation, this particular session is focused on teleconsultation, the future of it, and all the people here are involved in different aspects and from different outlooks, have different outlooks to teleconsultation industry. So I'll start with, Dr. Alex, because he's the veteran here who has been doing teleconsultation, to give a little bit of introduction about himself as to how he first started with teleconsultation, and then we'll take it from there. Dr. Alex.
Yeah, good afternoon, everyone. So Dr. N.K. Singh and me, we go back about 23 years. We have set up teleconsultation at those days we thought remote centers like Siliguri, Tinsukia, Chamarajanagar, probably around 70 or 80 telemedicine centers as spokes with a hub as Narayan Udayalaya. So there were only two big hospitals that was doing teleconsultation. But then without the help of technology, it was like, having two telephones, but both need to get to those telephones at the right time. So you had to schedule patients at the spokes in Tinsukia. The reports were sent in advance. All those were then, a gist of it was made, and each one would come and sit in front of the screen. In fact, we even did tele-ICU. We used to roll a television on some rollers and go from bed to bed and actually review the drugs and then get a very senior intensivist, and very few intensivists even today, but then even less intensivists. So yeah, changed a lot with technology. In fact, even gratification of payment those days was sending a demand draft by post to the doctors, but a lot has changed.
So Dr. Alex, you're at Practo. Things have changed in last several years. So what is working for, like if you define teleconsultation today, right? What will you define? What is teleconsultation today, right?
Yeah, technology has completely changed teleconsultation. And I mean, if I may just go back one step and say, I mean, the word telehealth, telemedicine, teleconsult, completely all different things, right? You can have as wide a spectrum you can have a robotic surgery from a remote place. You can have teleconsultation, you can have tele-ICUs today, which is a commonplace, tele-ophthalmology, tele-dermatology. But what has really changed, of course, COVID was one of the triggering factor. It's unfortunate that we tend to, paint an entire canvas with a single brush and just say this is good or this is bad. Even after the COVID, the experiences, you think of one incident in your life and then you say teleconsultation is bad because if you don't examine the knee or if you don't do a physical examination, how can you do teleconsultation? I really wish that was not the case. And going forward, I really wish every practicing doctor spends in his time a percentage of time in teleconsult and a percentage of time in the physical consult. And there's good and bad in both. I don't know what the percentage is, probably 90%. Saurabh would be able to answer this. The follow-up consult need not be a physical consult. I can see one very clear advantage of teleconsult. A colleague of mine who's sitting in the audience today, I remember her landing from Ranchi on a Sunday afternoon and calling me and saying, I would like to, if it's possible, I have a fever, I'd like to see some doctor. So off consultation hours, which is normally between 10 and 1 in the morning, 5 and 8 in the evening, there's no doctor available for you. Weekends and long weekends, there's no doctor available for you, right? There are specific disciplines like dermatology, even more, and I have the experience of a physical hospital, right? I tried to combine one of the hospitals that I planned, the psychiatry patients, the IVF patients, all into general medicine. Nobody who wants to see a psychologist wants to sit along with others and be seen getting into a room for psychological problem. So there are departments where they don't want to expose themselves. It could be a male infertility, it could be psychology. So there are very clear, what would you prefer? If you have a headache in the morning, which you can actually postpone, would you prefer going and stopping at a pharmacy and asking a pharmacist what to take for the headache and then spending the rest of the day because you don't have time and then maybe amplifying it to something bigger, or just pick up your phone and have a teleconsult and get a professional to answer your queries? We've had cases, and we've always talked about the remote areas being connected to the main cities. We have had cases where people have gone for a holiday and got stung by a jellyfish, which can be fatal. But then they connected on a teleconsultation and got a treatment. So I think teleconsultation, I'm mentioning teleconsultation, is here to stay. We need to differentiate. So can you do this for a broken bone? No, of course not. You need to go there physically. So one of the first things that we say is please direct the patient, be a triage. So take the advantage of teleconsultation and take the advantage of physical consultation. So
I'll move to Saurabh. Saurabh, you run a chain of offline clinics, right? So what is teleconsultation actively used by your doctors? In what format is it being used by your doctors?
Yeah, so number one, I'd like to correct. What we run is omni-channel, right? And I think one of the biggest planks for Meddo has been in support of what Dr. Alex just said, that we don't believe that the future is either online or offline. It has to be cohesive, it has to coexist, because that is the only way. Now, what you can decide is whether a patient goes to a different platform for online versus a different platform for offline, and so on and so forth. But the patient behavior is going to be cohesive, and it's going to exist across both the paradigms. So what we are trying to do is essentially build one platform which, irrespective of channel, is available to you for your care. So, and I think it goes back to multiple studies that have been done globally, right? And I think Dr. Alex also brought about what percentage of consultations are happening online versus offline. The most comprehensive study we have is from ZocDoc in the US, where the consultations happening online in US were about 14-15%. This was pre-COVID. During COVID, it actually jumped to upwards of 40-45%. But 14 months post the onset of pandemic, it had come back and settled again around 15-odd%. So that's I would say, in the user's mind, in the patient's mind, that's the broad split of what they're seeing online versus offline. And that behavior is driven more by the ailment, by the category or specialty of what they need help for, more than anything else, right? Also, use cases like follow-ons, et cetera, happen more, or we also prefer them to happen online versus them coming to the centers, because it's waste of everybody's time. Yeah.
So, if you look at the overall teleconsultation size in India, I believe, from my rough calculation, I don't have any industry report to back it up, is around 50,000 consultations a day across various platforms. Correct. And all that. I don't know what the number is for eSanjeevani, but private companies together, I think that's where the number is. Why isn't it 500,000, million, 5 million, 10 million a day? And I'll love to bring Dr. Singh in this conversation, because we saw the spike in COVID, but somehow that number came down. Did we not deliver the quality or experience in terms of consultation? Or is it that, what is it, what are we missing?
So let me take that, and then maybe Dr. NK can also add. I don't think it's about the quality at all. I think it's again, I'll impress upon the point that it's all about the need, the category, and the condition that defines what is the preferred platform. With COVID, it was excessively the need, because people didn't want to expose themselves. So that need, the moment that need went away, it had to come down. It's no surprise. If we are surprised by this coming down, I think we kind of somewhere fooling ourselves, right? So it has to be very clear on what are the specific use cases that will work best online versus offline. Again, I think sexual health, mental health, basic, GP consults, etc., can happen in the online paradigm or with roughly the same quality as you would do offline. However, and even follow-ons, right, in certain cases can actually be culminated online. But if you think about a gynae, any specialty case where you need a deeper investigation, we still today do not have the right technologies or even mechanisms to figure those out. So I think it has to be dependent on the use case more than should we be targeting X versus Y.
Over to you, Dr. Singh. What will it take to get to 1 million consultations?
Yeah, thank you. I think we have quite a few, I don't remember the exact number, but there is a large consultation that has happened in eSanjeevani. But I will take a step back, that telemedicine, when we started, I started learning, researching when the internet came to India. As a medical doctor, I was awakened to the possibility of what the internet could do. So we should expect the Tesla moment, so to speak, for many industries in the coming couple of years, which I would like to preempt and let kind of share this thought process. Now, telemedicine as a paradigm is not just about teleconsultation, but it's about a comprehensive approach to how we can make healthcare more equitable and accessible. Now, in a country like ours, with billion population and the number of doctors we have, I think it's first of all not that, while I agree with my colleague who have spoken about the scenario use case, the way how I have seen telemed in China, they have a different scale. I was consultant to the southwest part of China, in Kunming I was there. We had issue, and it's a right forum, we have internet, the telecom and the internet provider doing this. Connectivity was the issue. Somebody asking 45 rupees per minute for a doctor's consultation on a telecom time isn't meaningful, right? There was a proposal of that kind early in the earlier time. So I would say that the types of, how many of us are aware that there's an ABHA ID, and how many of you enable yourself with ABHA ID? Are you using one? The DHI or the PKI were not in place in India a couple of years ago. Today we have. We have DISHA. We have security enablement for digital data. Now without data, the value of what we could do over a transaction of an online or an offline nature becomes limited. So that's the first barrier. We need to digitize information, health record. Otherwise, health will always be reactive. Sickness happens. Your car breaks down one day, but you don't every time expect a breakdown. You do your washing daily, you do your insurance, you do your maintenance. When you do that for your car, why don't you do that to this? It's a question that we should introspect. And this awareness must go to every individual, every citizen must ask this in their own way. Educated ones in their own way. You have 4 buckets: those who are hypochondriac, those who are lifestyle oriented, those who are laggards, and those who are value-based. For each of those segments, there must be a proposition. But the data becoming digital is the first step. And the terminology has to get standardized and globalized. I can't be calling a screwdriver in my country and call it as a spade. So telemedicine is high time that we get granular. We have from the Health Parliament looking at global policy and terminology, come up with thought process like digital health. Now, it's an integration of various possibility where citizens can care for themselves. Self-care is possible by augmented intelligence that is coming in at the speed of light. We have those knowledge-based. Medical knowledge is doubling at the pace of 76 days. You can't keep pace. Specialists are only so many. So the reality that will hit us with our aging population, I think we shouldn't wait for another COVID to wake us up, right? That is the one barrier. All stakeholders have to come together to create this kind of awareness. We also have to understand that it's not always doctor specialty-led consultation, but a lot of primary care and secondary work that can happen at the physical level, at the local preferred care provider. So a small healthcare organization need to be enabled to become partner of a digital health ecosystem. So they can do physical as well as digital. And there must be a learning incorporation in the entire possibility of telehealth consult or telemedicine. I think those are all, and nursing-led models. We have to see that every time you break down a certain thing, doesn't go to the engineer who manufactures it. It becomes very costly. We should also see there's local capability that can be delivered. You have Blinkin, right? The last mile of Zomato, a quick response. So innovation has to come from young folks. Ideation can come from wiser heads, but getting it done on the ground should be of a global mindset, of a global interoperable nature.
Thank you, Dr. Singh. I think covers a lot of points about enabling the ecosystem that will feed into enabling the teleconsultation. I'd like to bring Yuvraj in. So from a regulatory perspective, there have been a number of issues, right? But government has been very proactive lately with various initiatives. So can you highlight those initiatives that will help us, let's say, get to 1 million consultations a day?
So, good afternoon, everyone. And to take forward what we have been discussing, e-Sanjeevani has been brought up, and this is one of the initiatives that government has been diligently working on, and we see that the last press release of around May says that there have been around 139 million consultations that have happened, teleconsultations that have happened on e-Sanjeevani. till that. It's a cumulative number, but still it's a significant amount beyond the approximately 50,000 that Rajat mentioned about. So I guess government is taking its steps in the right direction. It has built an enabling provision in terms of the NHA, which has been driving the digital mission in India. And I believe now it is the time for private entities like us to step up and get into this space, collaborate with the government, take up their initiatives, and take it down to the last man in the country. So one of the basic things which I believe which will make teleconsultation tick and take it to 1 million users per day, as you say, is basically if we can allow the customers the same level of trust and access to the doctor as in a physical setup. So as any doctor, probably Dr. Alex can corroborate this, when a patient visits a doctor, the first thing that he is comforted by the doctor, the presence of the doctor, the few words that the doctor speaks to him, asks him about, those are the things that brings the primary comfort to the patient. I'm not talking of the injury cases or the hospitalization cases, but the primary health care that happens is where the doctor, his presence in a physical setup brings a lot of comfort to the patient. Can we use technology to bring that level of comfort, that level of intimacy between the patient and the doctor? I believe it was not possible so far, given the technological constraints, the access to a smartphone or a high-speed internet. But given that we are sitting in 2023 with probably a pan-India 5G rollout just around the corner and a very strong 4G network all over the country, it is the time now, I think we should have technology setups which will provide users a similar level of comfort. Maybe from their home, may not be from their home. One of the ideas that I think we all should explore is that can we take this technology to the remote areas? Because consider a metro, anywhere you are living in this metro, you will have a doctor within a kilometer of your house. So for me, the use case of having a telemedicine app which connects me to a physician is not much. I can always walk down, I can take an appointment and go down to the doctor. But imagine, as an example was given of a tourist who was stung by a ray fish or a jellyfish, or a person sitting in a remote village in Assam. Probably that is where teleconsultation can bring the maximum value addition, and that is where we should be targeting our energies to.
So one of the points that I want to talk about specifically, at least what we've observed at MyUpchar, is that people don't want to pay for digital consultation. So we get a lot of traffic from tier 2 and tier 3. 95% of our traffic is from there. So we travel to these areas to figure out what is the use case, what is the behavior there. And what we realized was that people end up going to a quack or a PHC if the things are bad. And they are not in habit of paying for consult. They only pay for medicine. And if you look at global models, like you were talking about China and other models, the payout of consultation is being done either by the insurance or the corporate, not by the individual. In India, the entire payout is being done by the individual. And I think that's one of the other big blockers here.
So I think that also stems from the fact that technology is primarily, at least in India, technology and technology apps are being seen as something free. We use any app which is free. We use anything on the mobile, we expect it to be free. So I think that is where I believe that intimate setup, where the doctor interacts directly with the patient and brings him that comfort, it is that comfort which will make him pay. I visit a doctor, or any person visits a doctor, he is expected to pay because it's a one-to-one setup and the patient is getting some benefit out of that one-to-one setup. So if we can use the telemedicine to provide that kind of a setup, I believe the people would be at least slightly willing to pay. Maybe Saurabh can elaborate more on this because he has much experience.
No, I personally think that, and then sort of it's over to you after that. It's that people take teleconsultation as first port of call, especially in the rural areas, right? So they're not really in a dire situation at that time. When they become dire, then they're ready to pay anything. So is it that, or is it something else?
I don't think people want to pay for consultation at all, whether it's whether it's online or offline, right? So we're very happy getting a movie ticket and with that, a drink worth 400, 500 bucks, but वही 500 रुपए जब डॉक्टर को देने पड़ते हैं तो काफी हालत खराब हो जाती है, right? So I think there is in general a problem in paying, more so when it comes to online, right? Because somewhere in everybody's mind, the thing is that I'm not getting the full treatment. And I think that's the bit that needs to change dominantly, right? That one, how can we do and what all can we do to ensure that the two platforms are dominantly at par? In fact, if you ask me, it takes more effort for a doctor to complete a teleconsultation versus a consultation in the clinic or in their chamber, because they have to type it out, they have to ensure there are 3 other things that they're not missing out on, the cues that they would have very easily gotten if the person was physically present, versus in an online consultation, they actually need to ensure that each of those use cases or those potential differential diagnoses, they're ruling them out. So if you ask me, the doctor actually needs to do more work to figure out the right diagnosis in an online consultation versus offline. But you're right, the behavior is quite the opposite. And that's definitely, I think, one of the reasons why doctors themselves prefer looking at patients in clinic versus online.
So I'll correct myself and say, since you are an omni-channel consultation provider, what is the way forward? Like, we realize in our game that we have to go vertical, right? In your end, what steps do you take? What are you doing to attain profitability that everyone is looking for?
Yeah, so I think, like I said, so the idea the way forward has to be an omni-channel approach. The way forward has to be where you're creating care continuums irrespective of whether offline or online. When you do that, then you know that you're not, and let's say we're starting with, specialty specific, brands and chains as well. So with Uncover in dermatology, one thing we've done is ensured that dominantly the first consultation, unless it's for a laser hair removal or something like that, that consultation happens in clinic and the follow-ons can happen online. Whereas when it comes to laser hair removal, we're okay doing the consultation online as well. So you need to define clear pathways, medical pathways, on what is okay to begin online versus what is not. Number 2, and that triaging can happen whether on phone or through the app, any of the methods available. Number 2, I would say, the follow-ups, et cetera, again, clearly defined pathways on what is okay online versus what is not, right? So, in fact, when we built our platform, the first thing, when the doctor writes your reports, et cetera, and you get them back, the doctor has an opportunity to just say one of the 3 things: continue treatment, nothing needed, come see me. And these are just 3 buttons. So how do you make it intuitive? How do you make it very easy for the people to use, whether on the doctor's side or on the patient side? I think all of these need to come together as clear treatment pathways, SOPs, that will help people switch between these platforms much easier. That's how we can command, I would say, parity of payment across these 2 medias.
So Dr. Alex specifically told me no business questions, but he's from Practo, so we have to ask. How do you monetize teleconsultations at scale?
This is why I asked you not to ask me monetization questions. Yeah, it's scale. It's just scale. But I guess second opinions, super specialty care, medical tourism, I don't know why it's not being tapped. In the sense, I mean, today somebody in Africa is just getting the help of somebody locally there or here because they really, probably with ABDM and other things happening, if the government can actually authenticate that so-and-so is an endocrinologist certified from India, then the patient there knows that it's a government certified doctor. Otherwise, they don't know who they're going to. So they end up paying multiple people. These are probably some of the ways this can be monetized, but otherwise it's pure scale. Pure scale.
Dr. Singh, what's your opinion about it?
I think we have to look at innovative packaging of service as well. While I agree with both my colleagues who spoke, we have to look at how from a transaction-oriented pricing to a more value-oriented pricing, which would mean that encouraging the end user, need-based, to understand that it is not like we do one consultation, we pay physically as well, and doctors say follow-up for the next 6 days is free. Things like that is one example from the physical world. We can imagine more such thing in the virtual world as well, that a pre and a pre-surgical, post-surgical, a physician, a checkup, a medicine delivery, all can be packaged. We are in innovation opportunity. Imagination is our limit.
Yuvraj, you were talking about leveraging the various insurance providers. Can you talk a little bit more about the government regulations that are coming around, making that part of the insurance policy?
In terms of specifically speaking of insurance coverage under telemedicine, I think we still have a little way to go when the government will bring in specific regulations for telemedicine. But as an industry, I think we should be focusing on putting across our points to the industry, because as it has been brought out that this is a very difficult industry to monetize, because of the fact that people in general are not willing to pay out of their pockets, and the global examples say that it has typically been paid either by the employer or the insurers. So we can take up global examples and pitch in our requirements or pitch in the industry growth model based on insurance to the government, and we can see if we can bring in certain relevant provisions in the insurance.
I think there's two more things, right? So to this, if you look at most insurance policies today, they wouldn't cover outpatient at all. I think that's the first trick we are missing. Secondly, the people who are now with corporate insurances or otherwise, including consultations which are purely online, I think that disparity is somewhere our own to blame, right? And then to make sure that these consultations fit our, so to say, cost parameters, we are actually going for very, very young doctors, fresh graduates and so on and so forth, dominantly who are doing these consultations. I think the sum total of all of this is actually what we see here, that people do not want to pay for the problem that you laid out. The people do not want to pay for online consultations because that trust level, and I think Dr. Alex mentioned it initially, is not there. Because, and you can say it's a chicken and egg problem, but that's one of the things we are also trying to break, that the parity needs to be there, right? So it's going to be the same doctor who's going to consult you and give you the best guidance available to them at that point, whether online or offline. So why should you be charging different? We don't charge different, by the way. So I think it's somewhere a chicken and egg that we have found ourselves into. Pretty much, I would say, dug our graves ourselves, and now we're trying to climb out of them.
So time is up, so I'll just wrap up this session. I think we basically wanted to present different facets of teleconsultation. While the volumes are there, government is doing a lot of things on that front. The volumes can scale, but monetization has been a challenge. At MyUpchar, what we learned was that, if you do vertical integration by bringing in our own medicines, there is better monetization. So we are able to hit profitability by when we finally last year launched our own medicines. Same way, Saurabh's company, they are doing vertical integration by providing various treatments in the clinic. So there is a way out, there is a future, it's very bright. I think the challenge, and the models have to be different, In tier 1, you can get the sub-G in 10 minutes, but you still can't get the medicine and ambulance in 10 minutes, right? So those are enabling infrastructures, as we were talking, Dr. Singh was talking about. Those are things that we need to enable in tier 1. In tier 2 and beyond, there are other things need to be enabled. The trust is a factor. I think we have done a lot of work on that front, but still more is needed. Because ultimately, people said, koi kapde nahi kharidega internet se 10 years back, and everybody is buying clothes. In US, people buy diamonds online. So I think it's just a function of time, a lot more investment on our end as an industry to get there. Thank you, guys. Thanks a lot.
Gentlemen, I'll request you all to take a picture together. Once again, thank you so much, Dr. Kuruvilla, Mr. Kochhar, Dr. Singh, Mr. Patil, and Mr. Garg for that fabulous session. Mr. Garg, you can smile now. There we go.